Hi, I'm Dr. Robert Berry, and I'm an orthopedic surgeon, board certified and fellowship trained in sports medicine. I'm also the medical director of orthopedic sports medicine at Baylor Plano Regional Medical Center in Plano, Texas. With this presentation, we're going to discuss common shoulder and elbow conditions and their treatment. We're going to talk a brief bit about shoulder impingement, rotator cuff tears, acromioclavicular joint instability, tendonitis around the elbow, biceps rupture distally or towards the elbow region, collarbone or clavicle fractures, and arthritis of the shoulder. So there's a lot of things that can cause shoulder pain, and this is certainly one of them. One of the most common problems that we see with patients is shoulder impingement. And if we get more specific, specifically external impingement, and as you can see in this illustration, this happens usually acutely or can happen over a long period of time. Patients will present with pain on overhead activities, and often they will have referred pain, or they will actually come in reporting pain in their arm or their biceps region, but actually the problem is up in the shoulder area. When we actually examine patients, we find that they have limited range of motion, and also if the doctor moves the shoulder, we find that they have limited range of motion as well. There's a test called Hawkins, which is bringing the arm across the body or raising the body above one's head, and people will often report pain with that. Usually the strength is normal. When we look at radiographs or x-rays, we will find as we look from the illustration there from the left to right that bone highlighted in red becomes progressively hooked. The more hooked the bone is, the more likely it is to pinch the structures in the shoulder, and that's what we call a type 3 acromion or a hooked acromion. Often if we obtain an MRI, we'll see bursitis in this acromial region, or the space occupied underneath that hooked bone. So usually pain, secondary impingement, is in patients older than age 25. We have those tests that we just referred to, or impingement signs. There's usually not any evidence of instability, and they often will have an acromial spur or that hooked acromion. Anything that really narrows that space as we raise up the arm, which is in that illustration there. This is sometimes also referred to as primary impingement. Primary impingement is often treated with anti-inflammatory medications, or sometimes referred to as NSAIDs, physical therapy, injections in the shoulder, and physical therapy with these illustrations showing some basic shoulder exercises working on cuff strengthening. And when everything else fails, sometimes it requires arthroscopic procedures such as this subacromial decompression. When we talk about throwers, it's somewhat of a complex problem. And so there's things that we need to look for. Ultimately, we can certainly treat symptoms, but we would really like to get to the source of the problem. And so when we look at throwers, specifically pitchers, and in this talk we're going to use the pitcher as the foundation for throwing injuries, we see that there is a wind-up period of throwing, there's a stance phase, and this limb stability is something that we need to look at. And when we look at this illustration of this pitcher here, we can see that he is certainly stable on single leg support, and he is actually not tilting one side or the other. And so we have what we call a balanced posture, where there's minimal sway noted from the front to back. So when we analyze pitchers, we see these illustrations here, noticing that the hand is on top of the ball. This helps to prevent early external rotation, and in a position called supination, or where we turn the form upwards. It is very important to lead with the pelvis, but we want to prevent what we call opening, and so that means that the back pelvis or the trailing leg needs to be hidden, or late rotation of the pelvis, as we would say. So we want the lead shoulder closed and the stride foot pointed towards home plate. When we begin to accelerate, there's actually two phases. The first part is where the shoulder comes forward with the forearm behind the shoulder, and that's illustrated here. The second part is where the forearm begins to whip forward, and the pectoralis, or the chest muscles, and the latissimus dorsi, sometimes called the wing muscle, begins to pull that arm forward. In the next phase, we have deceleration. This is where a lot of injuries can actually occur. There's lots of force happening on the back of the shoulder, what we call the posterior capsule and external rotators. Increased stress on the rhomboids and levator scapularis, those are the muscles that actually help to support the shoulder blade. So, sources of pain in the throwing in the throwing athlete were initially classified by Job. We have pain secondary to impingement, we have pain secondary to instability, we have something called multidirectional instability, which is essentially generalized laxity, and something pain secondary to instability without impingement, and a new impingement classified by Walsh in 1992 called internal impingement, and we'll talk about that. So again, as we talk about shoulder impingement usually is chronic, and often people come in and they'll say, "Doc, what happened to cause this?" And often we don't know. Now, when we talk about pitchers or throwers like this, we have this marked sectional rotation, and we're doing these activities day in and day out, it certainly can cause significant pain. Often patients will present with this posterior superior shoulder pain, meaning pain on the top and back aspect of the shoulder, and it can be a combination of rotator cuff tear or something else that we call slap tear, and that stands for superior labral anterior to posterior tear. And that means that we actually have injury to the labrum from front to back. Well, internal impingement of the shoulder usually does require some surgery if it fails conservative measurements. We certainly try injections of physical therapy, and we rest from overhead activities. Rotator cuff tears are usually insidious. That means that it comes on over a long period of time, can be chronic, and just like in these illustrations, we see the tear. When we look at that illustration of the MRI, we see that arrow pointing to the rotator cuff tear, and there's usually weakness and limited range of motion. And with a chronic complete rotator cuff tear, sometimes people have no pain, but will have the inability to elevate their shoulder. That means raise their arm up, and so they'll try to kind of shrug the shoulder to bring it up. The exam can vary, and it can be dependent upon how long the tear has been there. Large rotator cuff tears, usually people cannot raise their arms up, but in small tears they often can. Subscapularis is a tear of a muscle in front of the shoulder, and we have what's called a lift-off sign or belly press test, and that means that if you were to put the arm in the small of the back, that you could not necessarily raise that off. Now, we can certainly fix these through a variety of means, and certainly when we have rotator cuff tears, especially full thickness tears, they often require surgery. We can fix it through the scope or open, but I'm going to focus our presentation here on the arthroscopic repair as what I do primarily. It is rare that I would actually have to make a bigger incision and open a shoulder. The benefits are smaller incisions, less pain, and some would argue faster recovery. So this is an illustration here, and looking at a rotator cuff tear, we see the arrows pointing to the humeral head, the cuff tear outlined by the red, and this is us in the operating room actually performing an arthroscopic repair. Well, when we look at this video here, we can actually see the cuff tear, and we have an arthroscopic device that's going to be introduced into the field, and this specific arthroscopic device is actually used in order to pass suture through the rotator cuff. We do this and pass this variety of sutures through the rotator cuff, and after we have completed passage of the sutures through the rotator cuff, we will actually repair this to the prepared surface on the greater tuberosity or the upper arm bone. And so this device is revolutionized the way that we actually treat rotator cuff tears. So instead of making very large incisions, we pass the suture through a very small portal, and then we actually would place these anchors, much like you would actually attach a tent. We place these anchors into the bone, we tension the rotator cuff back to the greater tuberosity, and then with this technique we actually have less pain, we have less morbidity, and usually a faster recovery. And so we can see here as we introduce these anchors into the bone, we have good compression of the rotator cuff on that. And so this is kind of my algorithm, if you will, of shoulder pain. And if someone has full or near full range of motion, we see that we will often initially start with anti-inflammatory medications, injections, and if they're improving, we'll continue with physical therapy. If they're not improving, then we will consider therapy, and an MRI may be ordered before that. If they have very poor range of motion, then we'll usually proceed with an MRI, although one could certainly consider injections. Usually it's good to have all the information on the front end before someone wastes a lot of time or money in physical therapy. Now, when we talk about an ideal pitching form, we talk about Tim Lincecum.
Tim Lincecum won the Cy Young in his first 2 years in the majors because he has a very efficient delivery. We will measure Tim's pitching efficiency with a special SOMAX analysis system known as Russia, or RSSSA, which stands for Range, Sequence, Separation, Speed, and Alignment. In this video, we will concentrate on range, sequence, separation, and speed. The bigger your range of motion prior to release, the more ball speed you can effortlessly generate as the parts of your body have more time to accelerate. So let's measure Tim's range during his pitching sequence. The stride angle is the maximum opening between the front and trailing leg during the pitch. Tim's stride angle is 128 degrees. The stride angle is important in pitching because the bigger the stride angle, the more time the pitcher has to get his body up to speed before contacting the ground with his lead foot. An efficient baseball pitcher makes use of his entire body to pitch, not just his arm. At the beginning of his pitch, he hurls his whole body toward the plate. As he touches down, he abruptly stops his lower body moving toward the plate, which then whips his upper body and arm forward. This is what happens to the occupants of a vehicle when it suddenly stops. Their upper bodies are whipped forward. A large stride angle combined with fast hip rotation enables a pitcher to use the large mass and bigger, stronger muscles of his legs and hips to power the pitch. Pitchers who do not have much leg and hip flexibility have small stride angles and large ERAs, as you can see here. They cannot generate much speed or have much control, as they have to overuse their arm to make up for the lack of power from their stiff legs and hips. Hall of Fame pitchers, by contrast, have large stride angles and long, successful careers, as you can see in Nolan Ryan, Greg Maddux, Sandy Koufax, Tom Seaver, Warren Spahn, and Juan Marichal. Lincecum rotates his hips a full 135 degrees prior to releasing the ball. He also rotates his shoulders 135 degrees, extends his back 42 degrees, and rotates his arm back 65 degrees. Tim could actually increase his pitch speed by increasing his external arm rotation. His external arm rotation, as we showed before, is 65 degrees, but other pros have more than 90 degrees, as you can see here. For an efficient range while pitching, you need a minimum of 95 degrees of hip abduction, 60 degrees of hip extension, 60 degrees of internal hip rotation, 110 degrees of trunk rotation, 24 inches of back extension, and 60 degrees of external arm rotation. Baseball pitchers launch the ball in a short orbit around the Earth. Satellites are launched into orbit with a multi-stage rocket. A pitcher is really a 5-stage rocket. Stage 1 is the legs, Stage 2 the hips, Stage 3 the shoulders, Stage 4 the arm, and Stage 5 the hand. A rocket launch and pitch are most successful if their stages are fired in sequence from the ground up. Tim does have an efficient sequence. First he fires his legs by taking a large stride toward the plate, then he rotates his hips, then his shoulders, then he rotates his arm, and finally he fires his hand. During a rocket launch, each stage separates, increasing the speed of the stages above it and the speed of the satellite. Tim has excellent separation between the stages. First he strides toward the plate, and then just before he touches down, he rotates his hips. After he has rotated his hips a full 90 degrees, he then rotates his shoulders. After he rotates his shoulders a full 90 degrees, he then rotates and extends his arm. While he is extending his arm, he is also flexing his wrist, and so does not have the best separation here. You can see the same kind of phenomenal separation in Hall of Fame pitcher Sandy Koufax, Less successful pitchers tend to rotate their hips and shoulders together, as you can see here. In order to achieve this kind of separation between the hips and shoulders, you need a minimum of 110 degrees of trunk rotation. Tim has excellent hip speed because of the flexibility of his legs and hips. Hip speed is important in pitching because it takes advantage of the hidden force multiplier built into every pitcher. The distance from the hip joints to the center of the body is 3 inches. The distance from the ball to the center of the body is 30 inches. 30 divided by 3 is 10. Any increase in hip speed is multiplied 10 times at the ball. It is the same lever system that enables you to fly a toy propeller. The distance from the outside of the shaft to the center of rotation is 1/8 of an inch. The distance from the tip of the propeller to the center of rotation is 4 inches. 4 divided by 1/8 is 32. The speed at which you turn the center shaft is multiplied 32 times at the tip of the propeller. This is why you can't get the propeller to fly by turning the propeller blade. There is no force multiplier in the propeller blade, just as there is no force multiplier in the arm. This is why lifting weights does not really help pitching speed. Tim, for instance, has never lifted weights, but throws his fastball 95 to 97 miles an hour or more. To increase your pitch speed, increase the strength and speed of your hips with the Power Hip Trainer. For fast hips, a pitcher needs a minimum of 60 degrees of internal hip rotation. You can learn how to test your hip strength by viewing our video at www.
Motion of one's hips. We need to actually consider this when looking at shoulder problems. And this is something that we do, and so this video certainly illustrates the importance of hip range of motion. So if someone comes in with shoulder problem, it's not surprising that we actually start our examination often at the feet and work our way up. We want to make sure that someone has good core strength, and if there's limitation in the range of motion of one's hips, then that means that someone's going to have to compensate upwards in the mechanical chain, and so that can actually put increased force in the shoulder. And so this video is very helpful in evaluating throwers, or specifically pitchers, and it really is somewhat of an ideal pitching form, and when we talk about throwers, it's something to consider. So when we talk about throwers, you have to be a problem solver, and just like this cartoon illustrates, it is quite funny to think of, but it is a very serious problem. When we talk about shoulder arthritis, which can be a cumulative effect from years of sporting activities, or insidious onset, which means it comes on over a long period of time. Osteoarthritis is a form that we most commonly see as opposed to an inflammatory type of arthritis, and usually x-rays make the diagnosis. Physical therapy can be used to maintain motion, and we can certainly inject the shoulder with steroids, and it's really the choice of the surgeon as far as what is used. All have similar functions. Viscose supplementation, or what we call these gel injections, or some people refer to as the rooster comb injections, is an off-label use and can sometimes be used. Replacement of the shoulder or resurfacing is something that can be done as well. So when we talk about shoulder replacements, there's several here. Certainly the one in the center there is kind of the standard shoulder replacement, and this is something that allows one to adjust it to the anatomy. In the upper right shoulder, this is a patient of mine where we've actually done just more of a resurfacing type of procedure, and in the bottom is actually another patient of ours in what we call a reverse total shoulder replacement. And this is someone who has a complete rotator cuff tear and is actually the preferred methodology for treating someone with that, and it essentially allows the deltoid or the shoulder muscles to then raise up the arm if that should occur. When we talk about another common thing that we see in athletes, talk about clavicle fractures, and most of the time these things do heal, but this is a severe x-ray of a clavicle fracture. Certainly you see the displacement, and then you see the treatment of this patient and how I treated it with putting a plate on it. There's approximately a 20% non-union rate in these comminuted fractures, and so there's more of a predictable healing by fixing them. Often we talk about clavicle fractures, and if we do elect to fix them, there often can be required a second operation in order to remove them. And I apologize for the text there kind of running into the picture. Shoulder instability is another common problem, and that means dislocation of the shoulder. It's usually traumatic. It's usually on one side, or what we call unilateral, and there's often a labral or Bankart tear associated with that. The recurrence rate for dislocation for young athletes is nearly 100% for those under age 20 and usually requires surgery. If it's atraumatic, meaning there's no acute dislocation, usually we'll try physical therapy for 3 to 6 months before considering surgery. If we do have to fix them, usually we'll perform arthroscopic repair. There's better visualization, there's less pain, and usually a faster recovery. Previously, open repair had been the traditional approach to this, but is now mostly performed arthroscopically by experienced arthroscopists or sports medicine surgeons. The important thing to consider is this can often be career-ending. This is a picture here of my former partner in San Diego, and as I was a physician caring for the San Diego Chargers, Drew Brees, who dislocated his shoulder. And I think everybody certainly is aware of this injury in this athlete. It's a truly amazing story, and certainly if you ever want to be inspired, you can certainly read Drew Brees' book, Coming Back Stronger, and really talks about the story of recovery here, of where he, playing one of the final games of the season in the NFL against the Denver Broncos, dove for a fumble pass on the goal line, and in the process of that was hit and subsequently dislocated his shoulder. And you can see my partner escorting Drew off the field here. But I think for everybody that knows the story, he certainly had surgery. He then ended up coming back, winning the Super Bowl and the MVP. And so certainly an inspirational story, and something to certainly consider when facing a potentially career-ending injury. And one can think of what Drew did to come back, and certainly I'm very proud of him and what he accomplished, and certainly he's still performing at a very, very high level, and so very proud of Drew and what he's accomplished. So here's an illustration of a patient of mine, arthroscopic procedure, where we actually, with the shaver, looking from back to front, we see the ball on top of the shoulder. And this person, the head would be to the right, the feet would be to the left. And so we debride or clean up the shoulder, and then we, with this arthroscopic instrument, mobilize the tissue. We place these anchors in arthroscopically. We then pass the suture through the labrum, which is the tissue that acts kind of as the support around like of a golf ball tee, and actually allows us to put the lip of the golf ball tee back up on the golf ball tee so it's stable, because as anybody has tried to put a golf ball onto a tee, it certainly wants to fall off. And so here's the final repair with a nice stable construct. Other things to consider in athletes are elbow pain, and we see this all the time, tendonitis epicondylitis, which means that the bony prominence is the inside and outside of the elbow, or a distal biceps tear. Specifically, we talk about golfer's elbow on the inside of the elbow, or tennis elbow, or extensor carpi radialis brevis tendonitis on the outside. Here's an illustration kind of showing that. Often happens from overuse activities. We usually recommend rest or anti-inflammatories and ice massage. We can certainly do steroid injections or PRP, which is platelet-rich plasma, and that's where we take your own blood, spin it down in a centrifuge, and then inject it into the area to promote healing. Ultrasound can be helpful. Ontophoresis, where physical therapists will often use pads with medications and electrical current to drive the medication subcutaneously into the area of injury, or phonophoresis, which is the same process, only using ultrasound. In patients that are somewhat non-compliant, I have been known to put people in casts, and it's certainly recommended to put the elbow at complete rest. Lateral epicondylitis or tennis elbow, incidence 1 to 3% of the general population, usually occurs in people 40 to 50 years of age. Usually the dominant arm is 2 times that of the non-dominant. In tennis players, sometimes considering excessive topspin or wrong grip, either using too big of a grip, too small of a grip, and usually we have some tenderness over the lateral epicondyle, and often the extensor carpi radialis brevis origin is to be considered. Usually we have pain with resisted wrist extension, noted as the Cozen sign. Initial treatment, as noted in the previous slides, is rest, anti-inflammatory medications. We'll actually use a brace. I'm not a big fan of the tennis elbow strap, and there's some evidence to say that it actually makes the problem worse. So I haven't actually used this in many years. And when all conservative treatment fails, we'll usually do a release of the extensor carpi brevis. This can be done arthroscopic, it can be done open, and if it's done open, usually suture anchors are used and we reattach that extensor mechanism. Golfer's elbow or pain on the inside of the elbow, noted as medial epicondylitis, can happen from repetitive wrist flexion or pronation, meaning turning the forearm or the palm downward toward the ground, and it's less common than the lateral epicondylitis. Injections, again, can be utilized, physical therapy, and in rare instances, open debridement can be performed with or without nerve transposition. Other common injuries that we'll see are distal biceps tear, and that means when the biceps muscle attached to the elbow has been ruptured. In this illustration, we see that. And then when the picture there in the center with the bruising is seen in the Popeye deformity where the biceps then retracts up into the upper part of the arm. Most common in 40-50-year-old age group. You can try rest initially, brace and sling, but usually whenever there's a complete distal biceps tear, physical therapy is not adequate, neither is conservative treatment. Usually we recommend surgery. Without surgery, conservative studies show you lose about 40% of the supination strength and 30% of the flexion strength. Now, a little fun fact is that John Elway actually had ruptured his distal biceps and his biceps tendon, and actually played football professionally with that injury. Here's the test that we do where we can actually flex the arm up. We can take a finger and you can actually feel the biceps tendon in the forearm there. So take homes, if you're actually having some of these problems we've discussed, never be afraid to punt. If not improving, see your doctor, and we certainly recommend that, specifically a sports medicine specialist or someone that's well versed in these types of injuries or problems. I hope you found this helpful. I'm Dr. Robert Berry. If you'd like further information, please feel free to follow us on our website or our Twitter account. We have other videos on our web channel that you can follow, and if we can be of any service, please not to hesitate to reach out to us. Thank you for your attention.